Hi, my name is Jackie, and I am a nursing student at Aspen University. Today I'll be discussing the eye and a couple of diseases that come along with it. So first we're going to start with the external structure. So for the external structure, you have the eyebrow, the eyelashes, and the eyelids, which all help to protect the eye from foreign debris, particles such as dust. Also, you have the bony orbits and the fat pads that help protect the eye from bouncing inside the skull. And then you also have the lacrimal system, which starts at the lacrimal glands and it goes all the way across the eye and drains through your duct and into your nasal cavity. That helps to produce like your tears and keep the eye moist. Then you have the sclera, which is right here. And what that does is it helps to protect a hard shell that also protects the eye. And then you have the cornea right here, which is composed of 6 layers, and it helps to bend the light coming into the eye. And you also have the external muscles outside of the eye, and what that does is it works with the neuromuscular control system to help move both eyes in the same direction. For the internal structure, you have the inner layer. There's 3 layers. You have the outer layer, which is where the sclera, cornea and the sclera are. Then you have the middle area, which is where the iris is kind of combined at. And then you have this innermost layer, and it stops right here back where the retina is. There are 2 different cavities inside the eye. You have this cavity right here. It's between the iris, and so the iris is right here, and the cornea. And then you have the posterior chamber right here, which is between the iris and the lens. I don't know why that says that. And it has mostly of your aqueous humor fluid. So there it is, the posterior cavity right here. And it has the cereal fluid inside of it. It's like a gel-like substance inside. Then you have the iris right here, which is kind of like a whole bunch of muscle structures, and what it does is it helps to restrict and dilate the actual pupil, allowing the amount of light that actually goes into the eye itself. Your lens is right here. It is a bioconvex structure. It is behind the iris, and it helps to bend the light also and raise to where it's supposed to scatter all over the back of the retina. The ciliary body is composed of muscles pretty much. It surrounds the lens right here, and it helps to hold it in place. Also, it secretes the aqueous humor fluid. And then you have the retina back here, which is where most of your vision gates are from. It has a whole bunch of rods and cones. Your rods are what's used when the light is very dim and dark. Your cones is what helps you produce the color of lights. And then there's always the arteries, and the little veins inside. And so, a couple of things that can't go wrong inside the eye is with the lens, especially, is what we call cataracts. So cataracts is the opaquency of the lens, which means it's pretty much like a cloudy thing. There is no cure really for cataracts, but there is surgeries that we can do to help get rid of some of that cloudiness so that they can actually see in the meantime. There are several different types of cataracts. So a couple of age-related or risk factors that cause the cataracts is age, blunt force trauma, maternal rubella, radiation exposure to ultraviolet light, long-term use of tropical steroids, ocular inflammation, genetic disorders such as Down syndrome or Edwards syndrome. Then you have your disease symptoms, eye diseases, which is your retinopathy, smoking, drinking, lack of vitamin C, long-term use of corticosteroids. Then you have the medical conditions as well, such as diabetes mellitus, metabolic disturbances, and then the Wilson's disease also. Leprosy infection can cause cataracts as well. So signs and symptoms that most people complain about is mostly the diminish of actual vision. They complain that it is dull. The colors really aren't as bright. They're abnormal colors, so they look faded. Diminished vision. It happens really kind of gradually, so they don't really notice it right off the bat. And another thing is that it's very sensitive to glare. Since the opaqueness is in there, once the light actually hits it, it kind of scatters it. So they get very sensitive to the actual glare, which is a really good test to use to test these people. It's called a glare testing to see if they actually have it. Then they can do double vision. They see sometimes halos, and some of them even complain of needing to turn on the light even brighter just so that they can read. So we said that the scattered glare test is a really good one to use, which it is. Then there's the visual acuity exam. There's the ophthalmoscope that can test too, and then the splint lamp microscopic exam as well. For these patients, they really do actually need the surgery to remove some of that protein buildup that's inside the actual lens. But when they're not actually ready for surgery, what we can do for nurses is we can do some non-surgical approaches, which is more or less changing the prescription of the eyeglasses, encouraging them to use stronger reading glasses, a magnification if they really need to, increase the lighting when they're actually reading. They can make lifestyle adjustments such as not driving at all at night or having someone with them to help drive. Nursing goals that we really want to do is educate these patients about the surgery, because the more education we give them, the less anxiety that they actually have. And then that way it also helps them to make an informed decision too. And then kind of assessing their anxiety level because it's kind of scary when you can't actually see and you don't know what's going on. So we need to assess their anxiety, see how they're actually feeling in all of this situation. And then another thing is just mostly we want to make sure that they remain free from infection if they do end up having the surgery. So we can do preventive, we can also help them do some safety modifications to their house as well, because these people can't actually see, they're at a huge fall risk. We want to make sure that they remove rugs, move potential objects that they can fall on, have someone assist them if they go upstairs, actually have someone walk with them. If they do decide to have the surgery, they're not going to be able to see right off the bat. So having meals prepped for them and stuck inside the freezer actually really helps. And then on top of it, just having them do some audiobooks as well if they really want to read. That way they have something to listen to, but they're not actually using or straining their eyes quite yet. Some health promotions is more or less just wearing some sunglasses, avoid exposure to unnecessary radiation, maintaining a proper diet and with antioxidant and vitamins, C and E, good nutrition, and obviously getting your eye examinations frequently. Let's see. Another thing that I want to talk about is the glaucoma. Sorry, I had that all mixed up there for a second. Nope, that's right. It's the sheet. It's mixed up. So another thing that patients will typically see is called glaucoma. And I think I dropped it, sorry. It is the second leading cause of actual blindness in the United States. Some of the risk factors of it is more or less just like genetic risk factors. It does increase with age. African Americans are at a higher risk of actually developing glaucoma. So we want to educate those patients that they need to go get their eyes checked frequently and more often. People are usually unaware of having the glaucoma. And it is a preventable disease. So it's one of those you really want to get in as soon as possible to try to do as much interventions to decrease the damage that it can cause. So what it is an increase of intraocular pressure inside the eye. And if there's too much pressure, it pushes up against the retina and it causes damage, which can cause permanent blindness. Once it actually affects the retina, though, it's not curable. We can decrease the intraocular pressure, but we cannot correct anything that happens to the actual retina itself. So there's the open angle glaucoma and there's the closed angle glaucoma. And they are pretty much determined off of how much intraocular pressure is inside the eye. So a normal intraocular pressure is anywhere from 10 to 21 millimeters. For an open angle one, it is 22 to 32 millimeters of pressure behind the eye. And then for the acute angle closure glaucoma, it is anywhere from more than 50 millimeters. Some other stuff that we can use to diagnose these patients is the splint lamp microscopic. You can also do the ophthalmoscope inside the eye as well. Visual acuity measurements, the tonometer, and then the gonoscope can do it as well. Most of these patients are, like I said, it's very gradual, so they don't really even notice the onset of it. But they complain of having like a tunnel vision because it starts from the outside and it kind of comes in, kind of like a little tunnel vision type thing. For acute angle glaucoma, it is sudden. It says that they experience, it goes around the eye. They can have nausea, vomiting, colors of halos. That's acute closure glaucoma. Nausea, vomiting, color halos of lights, blurred vision, and ocular redness. For chronic, it's just the history of unrecognizable symptom episodes, history of blurred vision, seeing colors, redness, and pain. So how do we treat these people? Our main goal is to actually just to reduce the intraocular pressure, because if we can control the pressure inside the eye and get it to be reduced, then it's not going to cause damage to the retina. So what happens in between these is that the open angle one is, it's kind of like one of these ducts right here is drained and it clogged and it won't drain, which causes that pressure to kind of build up. And then for the closed angled glaucoma, it's a reduction of the actual drainage, which then builds up inside the eye, and it can actually cause the bulging of the lens itself. So what we want to do is we want to educate these patients on medication to try to decrease the intraocular pressure as much as possible. And for nurses, that means we have to do a lot of teaching of how to properly administer eye medications, because what you want to do is you want to teach them hand hygiene. You want to teach them to place the medication into the conjunctival sac, not inside the eye, so it goes inside the sac. They tell them don't touch the eye whatsoever, because that can cause damage to the eye. It can cause the microbes on top of the actual dropper itself too. So, and then you want to make sure that you place a finger over top the campus and just gently apply pressure too, so that the medication doesn't go into the systemic either. And then we don't want to rub the eye. What they can do is they can close the eyes, they can move the eyes back and forth to kind of get the medication to go around, but they're not supposed to apply any direct harsh pressure or rub the eye whatsoever. And then also we want to educate them about 5 minutes. Make sure that there's 5 minutes in between the administration of medications. So they do one medication, wait 5 minutes, and then they can administer another medication. For these patients, we also want to teach them health-related promotion things, such as making sure that they go get their eye examinations. Normally, they're supposed to get their eye exams every 2 to 4 years for people at the age of 40 to 64, every 1 to 2 years for patients that are 65 years and older. Like I said earlier, the African American population, we want to make sure that we tell them to get them a little bit more frequently than that, just because they are at a higher risk. And it's more teaching patients about secondary prevention than anything, because the screening and early detection is what's really important about glaucoma, and then educating them about medication administration. So the third disease that I want to talk to you guys about is the age-related macular degeneration. It is most common in patients that are over 60 years old, and it is also irreversible. The risk factors for it is a white ethnicity, family history, chronic inflammation conditions, smoking, and hypertension. So your hypertension patients, a little bit older ones, have a possibility of actually having this. There are two types of age-related macular degeneration, which is your wet and your dry. The patho behind your dry is the yellow extralocular deposits get put back there onto the retina deposits. And then the wet one is that your eye has these new growths of veins, of vessels, the abnormal growth of vessels, and then they start to leak. And then once they start leaking, they actually scar. So what we want to, or what you'll typically see inside these ones is they'll complain of it getting dark. It's dark, blurred vision. They start to see blind spots, is what they'll say. There's a blind spot inside their visual field. Distortion of an actual vision is what they kind of say. Testing that you can do is the ophthalmoscope. Again, looking back there for Drinson. Or you can do the Amsler grid test as well. Educating these patients about glaucoma is very important. Early detection is, I'm reading up my notes onto the other one. The fundus photograph and IV autograph are some more ways that we can actually test these patients for this. So because there is no actual treatment for these patients, a lot of what we as nurses are supposed to be doing is more palliative care. We want to, we can educate them about the medications that can be used along with this, because what they try to do is do injections to kind of help, help with the vision, to help kind of bring it open. Some side effects though behind the injections is blurred vision, eye irritation, eye pain, and photosynthesis. There's a laser therapy also that's used for this. It's called the photodynamic therapy. Cold laser is what they call it. It can damage the retina vessels that are actually causing the leakage, to kind of try to prevent further degeneration. And mostly, like, we really want to teach these patients that this laser therapy, it's activated by the exposure of sunlight, and high intense lights can also from halogens, like in front of me. They need to avoid that, because up to 5 days after the laser therapy, because it can create a chemical burn is what it can do. So we want to teach them to stay away from those things, because the light can activate what the laser had done. Again, what we can try to do with these patients is kind of just assess their emotional status. We want to see what their support status is, be there for them as much as possible. And then we can educate them about dietary supplements such as vitamin E, C, and lutein and zinc, which helps with progressive advanced age macular degeneration, but it doesn't really do too much with minimal or non-evidence macular disease. They can find these luteins inside dark leafy green vegetables such as kale and spinach, which this has shown some evidence of reducing the risk of age macular disease, but it doesn't prevent it. It's and then also considering about talking about vitamin supplements to your healthcare provider, and then ceasing to smoking. So thank you very much. I hope that was educational, and I hope you liked it. Thank you.